Hello everyone. So today we shall take a look at this a condition that can also cause hair loss, non-scarring type, and this is what we call trichotillomania, and it is one of the psychiatric conditions that is associated with hair loss. So, according to DCM-5, it is classified under the obsessive-compulsive disorders and the related conditions, and it is one of the conditions that when you see, you need to manage together with a psychiatrist. You can't manage it alone as a dermatologist because it goes beyond the skin to involve the psychiatric aspect. As you can see here, you see this irregular pattern of hair loss, which you cannot attribute to any other condition. You see this irregular pattern in this picture that I've displayed. So in this case, this is one of the conditions we call the self-induced plucking or breakage of hairs, and that's what we call trichotillomania in our English. And oftentimes it's associated with psychological stress or any other personality disorder. And in this case, you'll have incomplete or undistorted follicular anatomy. When you do histology, because of the continuous pulling, you don't you just get distorted anatomy of the hair follicles. So the term trichotillomania is derived from from Greek word. The first one is trix, which simply means hair, then tilane, which means pulling out, and then mania, which means muddiness. So that's the word altogether, trichotillomania. Commonly seen in more in women than males, and more commonly seen in children and young adults as compared to adults. And oftentimes, when it occurs in these children, there's usually an underlying psychiatric or psychological or major problem that is occurring in this child's life. So every time you see it, you need to investigate further and address the other contributing factors. And when you do that, the condition resolves on its own because the hair actually has no defect. It is just being pulled out as a coping mechanism. So in the pathogenesis, this trichotillomania, as I had mentioned earlier, is classified as one of the obsessive compulsive and related disorders in the DSM-5. And this criteria, this is what we follow. So the first criteria is that someone should have recurrent pulling of hair resulting into hair loss. That is M. Then B, they should have repeated attempts to decrease or stop the hair pulling, but it is inevitable. So someone will tell you, I try to stop, but I find myself actually pulling out the hair. Then in C, we see that the hair pulling causes clinically significant distress or impairment in the social, occupational, or even other areas of functioning. So in this case, we know that in psychiatric conditions, it is not a psychiatric condition until it has an impact on someone's function, either socially, economically, financially, or even at work, or how it affects how they relate with others. That's when a psychiatric condition actually qualifies to be one. Then hair pulling or hair loss is not attributable to any other underlying medical condition or any other dermatological condition. So when you examine, there's no sign of alopecia areata, no sign of any other condition that can cause hair loss in that particular similar pattern. It is not a congenital condition. So this is like excluding other causes that can give you a similar manifestation of hair loss. And then in E, we see that the hair pulling is not better explained by other symptoms other than a mental disorder. For example, attempts to improve or a passivity defect or flaw in appearance of someone's body. So there's another condition, the ones we call the body dysmorphic disorder. In that case, someone is not confident about their body and they try to do something to correct the flaws that they think they have. For example, someone has a very minute scar or maybe on the forehead, but they think this scar is big enough to prevent them from getting married or getting a job of their life. So that's what we call the body dysmorphic disorder. So you have to make sure that the hair loss that someone has cannot be attributed to that dysmorphic disorder. So that's when you can say that now I'm dealing with the trichotillomania. So that is the DCM-5 classification. So when you look at the clinical picture, the common areas that are affected, oftentimes the areas that are easily accessible, oftentimes that is the scalp. So this will give you a patchy or complete alopecia sometimes, although hair pulling may extend to eyebrows, eyelashes, and even other body regions that are covered in hair, including the pubic area. So, or you find that someone will have irregular shapes of patchy hair loss with uneven borders and then varying hair length, because as you're pulling out, more hair is coming, so hair will grow at different lengths. So it will have even that rough texture in areas where hair is trying to regrow. And then the diagnostic tool, usually you can do what we call a hair growth window. In this case, you have repeated shaving of small areas, and then you demonstrate normal regrowth. Then when you do trichoscopy, you'll see these irregular broken hairs or with split ends, and then you can also see the V signs. In this case, this sign is what we call where you have the two equal length of broken hairs from one hair follicle. So you can as well see the black dots where the hair was broken, but maybe almost at the skin surface. And then you see those black dots, similar to what you see in alopecia. But in this case, you will lack the other features you see in alopecia. And the treatment, there is no definitive treatment in this case, but the approach includes things like behavior modification therapy, where you try to refocus someone's behavior and realign them with other things that can preoccupy their mind to minimize the cases of hair pulling. You can do things like hypnosis. You can do things like insight orientation psychotherapy. And in case all these non-pharmacological therapies fail, that's when we can opt for antipsychotic medications. And in that case, the first line is chlorpheniramine that can be used as a drug. But in case you're out of options, you can also use selective serotonin reuptake inhibitors, and this can also be used to try and treat trichotillomania. But remember, when you're treating this condition, you work in conjunction with psychiatrist or even a psychologist. So a dermatologist, psychiatrist, psychologist will work together in case you're managing trichotillomania in any patient. Thank you very much. God bless you. So when you look at trichotillomania, when you do pathology, when you take off a sample, you see that the hair follicles will be of normal size, and then the total number of hairs, both the terminal and the vellus hairs, will be normal, and you'll just get incomplete or disrupted follicular anatomy, but nothing major. There'll be no sign of inflammation unless when the area is now infected, and then you can get maybe neutrophils infiltrating the area with maybe staph infection. But significantly, in most of the cases, there's no sign of any inflammation. So this is how it will look like. And we have already seen these pictures. So in this case, this is how the regrowth was after therapy. Going back to the normal hair. God bless you. See you in the next video.